right, welcome to just the basics of chest X-ray evaluation. So this is just sort of my process when I'm going through these. So this is not to replace anything that's in the books, like your Wilkins patient assessment book or anything like that on how to read these. So this is just sort of me going through X-rays and what I've seen. So this is all based upon me more personally and the training that I got while I was in the hospital and from other physicians while I was practicing at the bedside. So just remember, take all this with that in mind more than this is something me quoting from a book or anything like that. So here we go. So when you're looking at an X-ray, the first place to start is by sort of checking these boxes. First thing always, and this is an easy test question for me, is this the right patient, right? Because there's people with multiple same names that are out there. So whenever you're pulling up an X-ray on a patient or looking at X-ray on a patient, pretty straightforward. Is this the right patient? Do their birth dates match up, right? So they could have multiple names out there that are spelled identically, but you always want to make sure the names and the birth dates match up and all that stuff too. So make sure you're looking at the right patient. You don't want to be making a diagnosis or changing therapy or anything like that when it's a completely different patient altogether. And believe it or not, this can still happen out there. So just make sure you got the right patient. Make sure you match up birth dates. Make sure you do all that stuff. That can happen. Just I don't want you guys to be someone where that happens to. Other things, when you look at these X-rays, you got to consider the differences between neonatal, pediatric, and adult X-rays. Neonatal X-rays, the heart and their tongue and their thymus glands, they're all going to be a little bit larger compared to their body size. Their head's going to be bigger compared to the body size. So things like that, something to pay attention to. What type of patient am I looking at? Neonate, pediatric, adults, right? So when we're looking at this, you do need to keep in mind some of the sort of idiosyncrasies that can change between the patient population. If you have an adult with dyspnea, then that's going to be a little bit different. You're going to be looking at more cardiopulmonary reasons usually. You have a pediatric patient with a sudden acute onset of dyspnea and wheezing, monophonic wheezing, you're going to be looking more for like a foreign body that they aspirated, or a neonate a pneumothorax, or premature lungs, and things like that. So you just got to sort of consider your patient population that the X-ray is on. Other thing too is the image reliable. So when you're looking at the image, you need to see if their collarbones are symmetrical, if their head was turned, if they were rotated. Is the X-ray considered underpenetrated or overpenetrated? So does it meet the requirements for a reliable image? Is it too opaque and making everything look opaque, or is it too dark and making everything look clear and than it actually is? So you need to look for a reliable image. And we go over this part too, and your Wilkins book covers this category as well. There are three things that we primarily look at here. Your Wilkins book goes into this in detail, but we're not going to go into that for this class yet, but you will in advanced diagnostics. What view are we looking at? So as far as views for diagnostic X-rays, so these are the ones where we have the patient go down to the X-ray, the radiology department, and then they stand in front of a big giant cassette, and then they take the X-ray from behind. It's called a posterior to anterior because it goes, shoots from their spine through their chest and then hits the cassette outside the front of their chest. So it shoots from behind and it goes through the front of their chest. So that's going to be more diagnostically valuable because we're not going to have impeding things like the heart, the lungs. All those things aren't going to be as modified by the technique. It's usually going to be about 6 feet away versus 4 feet away with a portable chest X-ray. And a portable chest X-ray is what's considered an anterior to posterior. So instead of the X-ray entering, the X-rays entering from the back side, from the spine side, and going through the chest, through the sternum side, they actually go the opposite. When someone comes and takes a portable X-ray or an AP, so anterior to posterior, the X-rays penetrate from the sternum and go through to the spine, and the cassette's behind their back. So if the cassette, that little thing that they put behind someone's back, if they put that behind someone's back, and it's usually a portable X-ray is where these are going, those can be good for looking at line placement and some basic things, and I'll have a comparison in here as far as diagnostics go. If we're looking for lesions, things like that, that's not going to be as valuable. It's still valuable in some aspects, but if you can get a diagnostic X-ray for the right person, that's going to be best. So PA is going to be one of your better ones. A lateral X-ray, we'll talk about that too. You can usually see some of the anatomy a lot better, especially the retroesternal airspace, and then I have some examples in here of that. Also, there's apical lordotic view. That's really good for looking at the top part of the lungs. If we think someone has a mass in the top part of the lungs, we can't get a CT scan or anything. They can do an apical lordotic view. And then there's what's called the lateral decubitus, and I have examples of that in here as well, where someone lays on their side, and it's a good view for looking at a couple of things. One of the big things that it can look for is pleural fusions as well, and how much pleural fluid they have going on in there. And there's more stuff, but we'll just keep it as basics in there. So views are a pretty important thing to just be aware of. What view are we looking at? What was the indication for the film? So that's one of the things that I want to know going into this. Was this a post-procedure? Like, did they get a central line and they had an X-ray? And why would we want an X-ray after that? Well, if they put that central line under their clavicle, they could poke a hole in the lung. It's called the subclavian central line, and that's a pneumothorax. And so when I'm looking at this, should I be careful to pay attention for signs of a pneumothorax, like the mediastinum being shifted and so on and so forth? So these are all things that I need to look at. Did they get an NG tube? Right? Am I looking for the NG tube going to their right main stem bronchus? Right? What's the indication? Did they have pneumonia symptoms? Right? Should I be looking for infiltration in interstitial spaces? So you should be aware of why they got the X-ray. Was it a procedure thing? Was it a diagnostic thing? And that's going to help you sort of pay attention to some of those more finer parts of the procedure. And then when we're doing or looking at the X-ray, we need to ask ourselves, does it make sense with the rest of the clinical picture? I could have a perfectly normal looking X-ray on a patient that's on a lot of oxygen, right? And so sometimes X-rays will lag behind because it has to be whatever disease is going on. Like, let's say it's a severe pneumonia. Whatever disease is going on has to be significant enough to show up on X-ray. And sometimes something can be very symptomatic but not be enough to show up on the X-ray. So you got to look at, does this make sense with the rest of the clinical picture, right? So sometimes the X-rays will lag behind the patient's condition a couple of days, and you will see this in the literature out there. I'm not the only one that makes note of this, but does this make sense? The X-rays can lag behind. I can have a patient that's about ready to get extubated off of a ventilator, and their X-ray actually looks worse. Well, the X-rays are sort of lagging behind. It's still showing that residual inflammation that's going on in their lungs. So that's something that we just got to be aware of. All right, AP versus PA, and this is what I was talking about first. So AP, so the first letter is the key thing to look at. The first letter is where the X-ray molecules or the X-rays went through first. Did they go through the spine? Did they go from posterior to anterior, or did they go from anterior to posterior? So if you come into the ER and you see the radiology technician put the X-ray cassette behind a patient's back, then this was a portable. This went from anterior to posterior, because posterior is where that cassette was. If you go down to the X-ray or radiology and get an X-ray done where the cassette is on front of the patient, in other words, it's in front of their sternum, then it went from posterior to anterior. So wherever that cassette is ultimately what will tell you if it's an AP versus a PA. Where do the X-rays start? Do the X-rays start traveling through the body posteriorly to anteriorly? Or do they start anteriorly, travel through to the spine posteriorly, right? So this is a big difference here, because what do you notice on this same patient, right? This is the same patient. What do you notice about the heart size between the two, right? The heart size here and the heart size here, right? So it's going to appear a little bit larger on the AP. What else do you notice? Do you see as much of the lung view on the AP versus the PA? No, the AP you cannot see near as much lung view, because remember, your lungs are smaller anteriorly than they are posteriorly. So as far as that goes, you're actually going to get less view of the lung tissue itself, because the way because the order of the x-rays going through the chest wall, right? So there are a couple things on here. Is if we're looking for diagnostic x-rays, if you can get a PA, it's going to be more diagnostically valuable than an AP x-ray. And so that's one of the things you'll be looking at here. Does it mean that an AP x-ray is useless? Absolutely not. This one's only taken from about 4 feet away, and this one's taken from about 6 feet away, around that area. So when you're looking at these things, you just need to be aware. If we're looking for masses or nodules or lung inflation or things like that, if you have a patient that's an emphysema patient and they just want to go in and get an x-ray done, and they're healthy otherwise, in other words, they're not in the hospital, then a PA is going to be a lot more valuable than an AP, because then you can see what their full lung expansion is, if they're hyperinflated or not, or if there's nodules, especially in the upper lobes, that we got to be worried about. So that's something just to pay attention to. Is it an AP or a PA? Because there's slight differences, but most of your hospital ones, most of your ventilator ones, they're going to be AP. So most of your hospital, if you're working more hospital stuff, you're going to see a lot of AP x-rays. And that's just, be aware the heart's going to appear a little bit larger. You're going to see a little bit less of the bases of the lungs, right? But that doesn't mean it's not valuable. So this is a lateral right here. So this is a PA and a lateral, or what you have here. The lateral means they're faced from the side. So this is the sternum up here, and then obviously this is the spinal column here, right? And so this patient's faced over to the side, and so then you can see their main stem. Hopefully you guys can sort of see this. Do you see that black line going down? You can sort of see it go into their lower segments, anterior, posterior, lateral segments. This would be a lateral segment right here. So you can sort of see from the side view as well. So you can see what's called, this would be at the shadow of the heart right here. And then this would be called the retrosternal airspace right here. I'll color in the retrosternal airspace. So that's something that we would actually look at too for some of the patients with small pneumos and babies especially. Usually you won't see an x-ray, you won't see the pneumothorax if they have a tiny pneumothorax on the AP. Usually you'll see it on the lateral x-ray. And then for COPD and emphysema, the bigger the stages, the more air trapping there is, the larger the retrosternal airspace is. And so that's something that we'll pay attention to. So laterals can be pretty valuable for a number of different reasons, but I don't want to go into that too in depth with you. So this would be a lateral decubitus. And so the big thing with this one, we're going to have the patient lay down. And normally the lungs should be symmetrical. Normally you should see exactly what you see with this guy up here, obviously, except for the heart structure like that. But you should see the same column shape. But down here, we have the, the same shape of the lung until we get to this flat point. And so that's a meniscus line. And so this is a very big sign of what's called a pleural effusion. So a bunch of free-floating fluid in the pleural space. So the advantage of doing this here, because remember, this is the rib cage down here. The advantage of doing this here, and this is your meniscus. So the advantage here is you can see the volume of the pleural effusion and how much thoracic if it was enough to consider doing a thoracentesis or let it absolve on its own, or if you are planning to do a thoracentesis, how much volume's in there. So usually anything over 20% of the thoracic space is considered significant enough to treat. And so if you have a small pneumothorax or a pleural effusion less than 20%, usually they're not going to treat that or put a chest tube in or anything like that. But this is just telling you how much is in there in that volume, because remember, the flow of that fluid will go, the to gravity, so that's why we have them lay on their side. So on your board exams, they always ask about position here or there for an x-ray. In a lateral decubitus, which is what this patient's in, right? They're laying on their right side, so this is right side dependent. That's the lateral decubitus is perfect for looking at things for like a pleural effusion, and it looks at other stuff too, but that's the big thing that we'll talk about here. Neonate x-rays. So neonate x-rays obviously looks a little bit different than the adult. What do you notice about the cardiac structure? The cardiac silhouette to the rest of the thoracic space is huge compared to the adult that we were looking at earlier. So that's something to look at too. The other thing you'll see is what's called a sail sign. It looks like a sailboat, like a sail. So this would be the cardiac structure. So the thymus gland is pretty big on these little guys. It'll eventually start to disappear as they get older and older. So it's called the sail sign, so that's nothing abnormal. But you're seeing a lot more cardiothoracic space on these guys. Obviously, you'll see that their joints are further apart, things like that. This kid's collarbones are not symmetrical, so that means there's rotation, which is why their trachea is sort of not lining up with the spinal column when it comes back there. So you'll have some minute differences, and I have some more neonate x-rays in this presentation. Pediatric x-ray. This is a pediatric x-ray. Still you see a cardiac silhouette that's somewhat larger in space compared to an adult ratio here. And so you'll see some of those minute differences. Obviously you see that the bone structures are closer to each other than what we were looking at previously. Collarbones are symmetrical here. You can see the front part, the spinal processes through the trachea, so this patient's lined up directly. This kid has some viral things going on, but that's a whole separate issue there. But you're still going to have a little bit of abnormalities compared to an adult one. Mostly it's still that cardiothoracic size. So this is like a 6-year-old, 7-year-old chest x-ray, somewhere in that area. So it still hangs around for a little bit until you get to the teen years. So what method do I use? So the big thing that your Wilkins book talks to you about is getting a technique down and sticking with it. And so when I was working at the hospital, I did the A through I technique, and that's what was taught to me by pulmonologists, and that's what I used, and that's what I got comfortable with it, and I was able to actually see everything that I needed to be able to see on the x-ray when we're looking at it. The other thing too is try not to rush these, take it slow. You might miss something that's important. So when we're going through these, I have some towards the end that you'll look at, and so hopefully just take it slow, right? Unless you're trying to diagnose a pneumothorax right away, right? Take it slow. The other thing to consider is how does this image, so after we look at an x-ray or when we're looking at the x-ray, how does this image change what we know about the patient? Right? So do we now see something new that's going on that do we need to address with a new therapy? Right? Should this image change what we're doing with the patient? Right? Should we add a mucolytic if it looks like there's a lot of thick secretions, or if there's a lot of inflammation, or if it looks like a bacterial pneumonia versus a viral pneumonia, which I put those two comparisons in here as well. Should this change our drugs that we're using for the patient altogether? So this is where this can come in very, very handy and alter how we're helping the patient get through this process together. So how does the image change what we know? Right? Do we see signs of cardiopulmonary disease? Do we see no signs of cardiopulmonary disease? Sometimes we're just taking the x-ray to rule things out, right? So that's some of the things that we'll be looking at here. So should this image change what the patient's getting? Well, that's what we're going to see, right? If we see a bacterial pneumonia going on and we've been treating them with viral pneumonia, that's a whole separate thing. Let's do a CBC, look at their white blood cells counts. Let's look and see if they're left shifted, if they're neonate, so on and so forth. So basic anatomy, I know you guys have probably gone over this before. The trachea, of course, the big thing with the trachea, and you'll see this on this picture, is you see these little spinal processes back there, right? So you should see those through the trachea. If you don't, that's a sign the patient was rotated, and it can alter the size of the heart, all that other stuff. So seeing these little spinal traces, and I should pick a different color here. Let's pick green. So you want to see those. And so the big thing with seeing those is it just allows you to know that the patient was aligned perfectly. Because if the heart, let's say that this patient was faced towards their left, right? Well, the heart is in the left side of the thoracic cage for almost everyone. And so that means the heart's going to appear bigger if they're faced towards the left. Well, then you're thinking, oh, this patient has cardiomegaly. They could have congestive heart failure. If the patient's rotated a little bit to the right facing, okay, that means the heart's going to be a little bit scaved. So that means the heart's going to look smaller than it normally is. So if a patient does have heart failure or does have cardiomegaly, we may not be able to pick that up. Right, so that's some of the things that we're going to be looking at. Is this image reliable? Can we see the spine through the heart silhouette? Right, you can see the separations of the vertebral columns here. That's a good sign. That means the film's not over-penetrated or under-penetrated. So that means that it's not more opaque than it needs to be, or it's not too more radiolucent or darker than it needs to be. So in other words, it's the right density to get the right diagnostic value out of this. So those are some of the things that we'll be looking at here. Of course, the trachea, I love following the trachea because then it goes into my main stem. So that means my carina is right here, and my left main stem's right there. So I can sort of see my separation there. If you can't see it right now, that's okay. It took me hundreds of x-rays before I got all this stuff down. Obviously the diaphragm. The right diaphragm is going to be a little bit higher than the left diaphragm because there's an organ over here. Do you remember what organ this is? Under the right side of the lung. Hint, if someone is a big time ETOH abuse person, this one will be enlarged and therefore impede it. Right, it's the liver. That liver can push up. So if someone had hepatomegaly or hepatosplenomegaly, that right side could easily be pushed up. So it's normal for the right hemidiaphragm to be a little bit higher than the left. Of course, the aortic knuckle here, so this is where you see, and I had a doctor explain this to me as the moguls. Let me pick a different color. Let's try yellow. So she always explained it as you want to see the three moguls. So the first one's going to be the aortic arch. The second one's going to be the right atrium, or sorry, the left atrium, and then or the pulmonary artery, and then you want to see the left ventricle. So you want to see these three moguls when you're looking at the X-ray. So here you see 1, 2, and then 3. And so that's what you're looking at there. Is you want to see those moguls, you want to see those cardiac structures there. This person has some air bronchograms. They have definitely some intrapulmonary conditions going on. These things that look like hoops in there for sure. So just some basic things that you'll see here. When you're looking at these also, don't ignore looking at the bones here and there, even though these are not usually done. So you want to make sure that the bones are intact. You don't see a fractured clavicle, you don't see fractured ribs, things like that. And the other thing too is these ribs, these are posterior ribs because remember they curve up like a McDonald's arch. So because they arch or curve up, these are posterior ribs. If you're looking at the chest cavity or the rib cage itself, they go up, they curve up posteriorly, and they curve down anteriorly. So these are curved up like a McDonald's arch. So those are posterior ribs that you're looking at there. So I do the A through I technique, and so we'll start with the apices. And one of the big things that you want to pay attention to with apices, especially with a lung cancer patient population, and other things can cause this, is what's called a coin lesion. Now, a coin lesion is where it looks like you have a coin hanging out in the top part of your lungs. So I've circled it there. So that's one of the things that you will see here. Now the A through I techniques, A is for apices, so I'm going to review the apices first. You can see other things like bases. I'm going to look at my costophrenic angles here. D is for diaphragms. I'm going to count the ribs. E is for esophagus if they had a NG tube. F is for fissures. I'm going to look for their fissures. If they do have it, that's not a good sign. G, gastric bubbles. H is for the hilar infiltrates. This person does have hilar infiltrates, and we'll go over that. And I is interstitium. They don't seem to have much ground glass. They have more of a viral thing going on here too. And then J, well, I only do A through I, so we'll go through just the eighth right today. But what do you notice about this one? You see how high the clavicles are up here? You guys all see how high those clavicles are? So this is what's called an apical lordotic view. So if someone has something funny that's going on in their apices, something that showed up a little weird on the normal x-ray, whether it's a PA or an AP, then they can do what's called an apical lordotic view to get a better view and get the clavicles out of the way so we can see the apices better. So one of the things that on the board exams they might ask you about is if a patient has something in their apices that they want to evaluate closer on an x-ray, what position do you want them in? You're going to say apical lordotic. So here's the apical lordotic position that the patient's in. So when they're taking this, so this would be an AP x-ray, or let's do it in a different color because I like purple, why not? So this would be an AP x-ray because remember the cassettes back here were the x-rays. So the x-rays go from anterior to posterior. So this is an AP x-ray. And this gets the clavicles up and out of the way so we can see the apices that much better. So the idea here is if there's something weird going on in the apices, we'll be able to get a clear picture of. Now realistically, as long as there's something called a CAT scan around, they'll probably go ahead and just do a CAT scan. It's going to give us a lot more information. I'd love to go over CAT scans with you guys. I don't have the time in this class, but I'd love to go over CAT scans and interpreting and reading CAT scans with you guys, but not right now. So the apical lordotic picture will give you that good picture of the apices without the clavicles getting in the way. Because remember, the apices of the lungs go above the clavicles, right? They curve up and higher than the clavicles, so that gets them out of the way. Well, why the apices? Why would these things show up in the apices? Some of the things that can show up, nodules like TB granulomas from tuberculosis, and other things like lung cancer nodules, if it's a non-small cell carcinoma, that would show up in the apices. It's more common in the right upper lobe, and so that's some of the things that you'll be looking at as well. So this is an apical lordotic, right? You see how high the clavicle is up here. So that's going to be one of the things that you'll look at here. So that way we can evaluate the apices without the clavicle sort of getting in the way. So this is rib number 1, 2, 3, 4, 5, 6, 7 to 8 ribs here, which is about normal. You usually have most of these x-rays, the patient's supposed to take a full deep breath in and then hold their breath for the x-ray. So it's going to be an inspiratory hold. And that's supposed to tell us sort of how much lung expansion the patient has. So if they're holding their breath and they only have 6 ribs that we can count, then that's a sign that their volumes are very, very low and they have a restrictive process. So that's something that we'll have to look at there too. But this is just an example of an apical lordotic and how much the clavicles sort of moved out of the way with that picture. Right, and so here I know this is starting the bases, but here when we're looking at this, do you see how the clavicles are in their normal position? This is not an apical lordotic, right? The clavicles are sort of in that normal position, and so they're sitting here, so the lungs actually do curve up and start above. So you have 1, 2 ribs above the clavicles, and then 3, 4, 5, 6, 7, and 8 ribs going on here. So just sort of letting you sort of see the different things. So A is for apices. So that's the first thing you look at. Do I see anything weird going on in the apices? Do I see any coin lesions? Do I see any densities? Do I see a pneumothorax where there's black, right? And I have examples of pneumos there later on in this presentation. But B is for bases, and I'm going to look at what's called the costophrenic angle. So that's this angle right here, and then it's circled over here. I'm going to look at this costophrenic angle. I want to see it sharp. I want to see a sharp angle there. If I don't see a sharp angle there, I could have something like what's called a blunted costophrenic angle. And this is a classic board question, right? Where I don't have the angle, I just have it look like a box, right? And if that happens, then that's a sign of what's either a paralyzed hemidiaphragm or a pleural fusion. Something's going on that's not allowing my base to expand. right? So if I have a bunch of fluid in my pleural space, it could be restricting or pushing that up. You know, things like that could easily be going on. So when we're looking at this one, here's the one that we talked about on the right, a normal costophrenic angle, right? Very, very sharp. And over here, what do you notice about this costophrenic angle? Very, very poor. This is a pleural fusion, a very, very significant pleural fusion going on with this patient. So I would guess this is probably at least a 1 to 2 liter pleural fusion at least going on. So you see how this is what's called a blunted costophrenic angle. Extreme example, but I just want you guys to sort of start to be able to recognize it, and then you can sort of notice it better down the road. And then this is me just highlighting the trachea and the main stem carina. Once again, you notice that the left main stem is a little bit flatter of an angle than the right main stem there. I always like to identify the trachea and the main stem, especially because that can tell me how severe a condition is. As long as the patient's not rotated on the image, then I can see that if their trachea and the main stem is being pushed one way, or if it's being pulled one way, then that's a sign of how significant their disease is. So we'll go over that more in disease class, but that's why I always try to identify your carina and main stem and trachea in these. And you guys will start to get to realize it more and more. Obviously it's not as big over here, but so this would be a blunted CP angle that you see on your left, and on the right is that normal, where you see a normal costophrenic angle, right? You want to see this sharp angle over here. You don't want to see something flat or scooped out. That's a very, very poor sign. Cardiac, A, B, so apices, we looked at the top of the lung. B, we looked at the bases, we looked at the costophrenic angle. C is cardiac. I want to see my moguls, right? I want to see my aorta, my pulmonary artery, and my left ventricle. Those are my 3 moguls, right? You could even draw a little skier going down these moguls, right? Yay. So when you're looking at this, you want to see also the cardiothoracic, how much size the heart's taking up compared to the thoracic cage. Now in this x-ray, this is a normal ratio, right? So this is a PA x-ray, and AP, it's going to look closer to 50%. So remember, the heart looks bigger because the x-rays are starting at the heart side. So it's going to cast a bigger shadow on the x-ray if it's a portable or a AP x-ray. So you just got to consider that too, but we want to look at how big the heart is. That can give us some good signs. So over here, you're seeing cardiomegaly. So this is a normal heart here. Let's use purple. So here's a normal size cardiothoracic size for an adult. And then when we're looking over here, we see that this situation here, you see how much more dense. You still see your moguls, but you see how much more dense this cardiothoracic structure is, right? A lot more dense, a lot more density value. There's a lot more hilar infiltrates too going on. This pulmonary edema, this is heart failure, so this would be cardiogenic pulmonary edema going on over here. So you see how much bigger the cardiac space is taking up the thoracic size compared. So that's what you're looking at there. And then over here is a case of hyperinflation. This would be emphysema. And one of the classic signs of an emphysema x-ray, and I will ask you this in disease class, so get ready, is going to be that tall, narrow column type heart. Because you see how tall and narrow that is? It's because the lungs are squishing it. They're being pushed in with all this hyperinflation. Right? They're being pushed in. So that's a big, big no-no. Obviously, restricting cardiac motility is going to be the big thing. That's where you get things like pulsus paradoxus, right? Or also known as pulsus alternans, where you feel their pulse getting weaker when they're breathing in because their lungs are squeezing the heart, and their pulse gets stronger when they're exhaled because the heart is now allowed to expand a little bit. So that's something that you might see with someone's severe air trapping. Well, I just picked an emphysema x-ray for you to sort of see here, but that's one of the classic signs of emphysema, is that tall, thin, narrow heart on an x-ray. So if you're looking at an x-ray and you see like rib after rib after rib, right? It's a lot of volume expansion. Not only that, but that volume is expanding so much to the point that that heart is just tall, narrow, column-like. ABCD. D is diaphragm. So we looked at their apices, we looked at their bases, we looked at their diaphragm. Now this is where we're looking at how much volume their lungs are containing. Do they have a restrictive process? So like I said, most of these x-rays are supposed to be taken, patient taking a full deep breath in, hold it, and then their x-ray is supposed to be taken. Well, if the patient's on a ventilator or they're on machines, they may not be able to coordinate that well. So take that sort of as what you're looking at there. So here you're counting the ribs, and normally you should see roughly about 9 ribs expansion. Remember, these are all posterior because remember they curve down. They start at the spine, curve up, and then down, and then you can sort of see the shadow of it coming. I'll use a different color. You can see the shadow of the anterior rib there. So that's sort of it coming down towards the front, but the x-ray is penetrating further than the anterior ribs. So you want to look at the volume. If you only have 6 ribs expanded, obviously, then you would have some sort of big restrictive disease going on. If you had 10 ribs expanded, then that's a sign of hyperinflation. So you have some sort of air trapping or your settings on your breathing machine. Too extreme, right? So that's how it would be to turn down some of those settings. So this is a good sign of sort of seeing restrictive process or a hyperinflation process. Okay, A, B, C, D, E. E is esophagus. So this is something that's soft tissue. Remember, the soft tissue esophagus is not something that's normally going to show up on an x-ray. It's not something that you will be able to typically see unless they're doing a barium swallow and it's a live x-ray. So that's something sort of different. You'll sort of know about that when you get there to it. But what we're looking at here is more traditionally line placement. So what we're supposed to see with an NG tube placement, and this is important for us. So if the patient doesn't have any G tubes or NG tubes, the esophagus is not a proper thing. Normally when a patient has an NG tube or an OG tube, it should sort of snake its way. Let me use a different brighter color. Let's use red. It should snake its way, which it sort of does here, and it should terminate somewhere in the stomach. Now, if it's what's called transpyloric, which is okay if it's like a dot pop or whatever, it'll cross over the spinal column. That's okay, right? What you don't want to see is over here on your right. So it went down, and then they kept advancing it, and it's like, oh, I'm going to make my way into the right mainstem. So that's one of the indications for a chest x-ray is before they use an NG tube, even though they can verify that they hear gurgling when they push, what they do to verify that it's in position without the x-ray is they hook up a big syringe to the NG tube and push it while they're listening over the stomach. And if they hear gurgling in the stomach, then they know that they're in the stomach. That's great. But sometimes people hear things that they don't really hear. I don't know if that makes sense to you, but they believe they hear something that's probably not there, and it happens, right? No one's perfect. And so what the idea here is that after an NG tube placement, they would get a portable chest x-ray just to make sure that the tube goes into the stomach. Because what happens if they put the tube into the lungs and turn on the tube feeding? And this has happened to patients I've taken care of multiple times. Right? This still happens. So they get the x-ray before they start feeding is the idea, and the x-ray is supposed to make sure that this tube is in the stomach and is not in the lungs. So now let's say we started tube feeds. and these tube feeds are dumping into the right lower lobe. Do you think that could cause a pretty significant pneumonia? Absolutely, right? The lungs aren't designed to absorb all that good quality nutrition through their tissues. So that's something very, very bad. And so that's something you want to pay attention to. So that's the E's. Make sure there are lines or the esophagus, that if there is something in the esophagus, that it terminates in the stomach. F is for fissures. Don't you love my little A through I technique? A, B, C, D, E. So apices, bases, diaphragm, A, B, C, D, E, esophagus. F is for fissures. So this is what we're looking at, your lateral and your oblique fissures. So you have your lateral fissure on the right lobe, and then your two oblique fissures left and right. So that's what you're looking at from the side view and from the anterior view here. And so normally, are you supposed to see these? No, you're not. So if you do see a fissure, it's a bad sign. That means they either have a lobar pneumonia or they have a small pneumothorax, more common on babies here, in between the fissures, or they could have some freestanding pleural effusion that's hanging out in there. So there could be a couple of different things going on in there, whether it's inside the lung or outside the lung, like I said, even with the pleural effusion. Usually if you see it with a pleural effusion, it's more of your exudative, your thick infectious disease type pleural effusion. So this is what you're looking at here. Do you see this fissure, right? Pretty significant fissure. So yeah, of course we see the oblique fissure here and then the lateral fissure over there. It's a big sign that we have something going on, whether it's a pneumonia or something else. Something big is going on here. This patient has a history of a mitral valve replacement. You can sort of see it there. Then you can see their sternum was sutured. Hopefully you guys can see that. So this person has a big history here, and so they have probably, I'm guessing here, a pleural effusion that's pushing in there, and so this is all that fluid going in the pleural space that's restricting that right lower lobe from expanding. So that's my guess, right? I'm not a radiologist or a physician, but that would be my guess here. But you can sort of see how you can see that fissure, and this is just being all that fluid just collecting that space and just sort of pushing up there on this patient as well. So if you see a fissure, right? If you see these fissures, that's a bad sign. That means something's going on in those areas. And so we need to start figuring out if it's outside the lung, like a pleural effusion, is it big enough that we need to drain it? Do we need a lateral decubitus? Do we need a CT scan, right? Is it inside the lung, like a lobar pneumonia? If it's a little neonate and we see the fissure there, could it be something we could just do a small needle for their pneumo, right? So that's something that we'll be looking at. A, B, C, D, F. G, gastric. So this is where we're looking for things like gastric bubbles, or what do you guys see here? And I know it was in your little thing before. This is the lateral view, and then this is the anterior view on your left, right? Hopefully you said hiatal hernia, right? So these are just different things that you'll look for. You'll have patients that have a lot of issues, more of your older patients that have some of these issues. But the most valuable place that I've used this is on your right here on this screen. This is a neonate x-ray, right? You can sort of see a little bit of the differences. You see how much space there is in between, all right, their bones and all this other stuff. Right, so these little guys, their chest is already taken up. A lot of it is already taken up by the heart, as it is, right? Their cardiothoracic ratio, and then now you add a big giant gas bubble in there. What's that going to do to your left lung? Well, that's going to restrict it from expanding, which means are they going to be able to get as much oxygen into their bloodstream if they don't have as much tissue that's expanding, right? So this baby can easily dissat and have trouble breathing. I called it Thanksgiving syndrome. Right after some feeds for these neonates in the NICU, the babies would start to desaturate, and I would ask, what's going on with their feeds? And they'd be like, oh, we went up 20 calories, or, you know, we added some more volume. right? So that means more gas can get in their stomach and then restrict their lungs from expanding, which means less ability to get oxygen into the bloodstream, which means they might desaturate after a big meal. So I call it Thanksgiving syndrome. It's nothing to do with tryptophan. It's due to the abdominal restriction on the lungs. Right, and so that's what I was talking about there. So they'll put the NG tube to air, right, and sort of let some of that gas bubble come back out. Now this kid has a pretty significant gas in his transverse colon as well. So this kid has a lot of gas going on too. So gastric restrictions, something that we'll have to look at as well. Sometimes even adults have a significant gastric restriction. Here's the diaphragm that I'm highlighting on your left here. Do you see the gastric restriction? Pretty significant there for that patient. So the same thing here, right? A big enough gastric bubble could cause some cause some of that lung tissue to not expand and therefore desaturate a little bit, cause some dyspnea. So adults not as much because we're not taking up as much percentage of the thoracic cage with the gastric bubble as it is with the kids. So it's more of an exacerbated problem with kids than adults. Now adults, we do have that problem as well, especially if they've been, let's say we've been using an ambu bag and mask and we're doing CPR and we haven't intubated the patient. So we're bagging the patient and let's say most of that gas, some of that gas is going to their lungs, yes, but is it possible some of that gas can be going in their esophagus and heading right into their stomach? Absolutely. And that could be causing gastric distension as well. So that's something that we should be aware of. So that's something in kids, right? That's something that I look at too. All right, so this is something, does anyone know what this is? So this is what's called a scaphoid abdomen. You see how this kid's belly is sunken in? So when you see that belly sunken in, that's not normal. Kids should have this poochy Buddha belly going on, right? And so when you see that, it's called the scaphoid abdomen. And so that's not a normal thing. And so what you're looking at over here, this would sort of be the same kid. And this is the ET tube that I'll highlight up here. Obviously, this kid's face towards the right. You see this area, no lung tissue expanding. And then over here, this is not lung tissue. Right, this is all gastric tissue, and this is all gastric. This is all gastric stuff. Well, what happened here is this kid has a congenital diaphragmatic hernia, or CDH, and most of their bowel, when they were in utero and they were developing, their gastric contents were developing and going into the left side of the thoracic cage. So this whole thing here is actually bowel. And so you would actually hear bowel sounds in the left side of their chest. And it's more common in the left side than the right side. So it's called a congenital diaphragmatic hernia. And if it's not caught, it still has a high mortality rate with it. But so that's something in there that you would see if you see a kid that has a scaphoid abdomen. Do you want to just give that kid a lot of positive pressure that can go into their stomach and expand their bowels and cause gastric insufflation? No, because that would impede even more on whatever lung tissue they do have. Because what happened here is, do you think that this left lung really developed if it's being crushed during utero development? Absolutely not. So that left lung is going to be very small, very hypoplastic, and so that's going to impede this kid's ability to breathe and survive, especially if they're premature here. So this is a CDH, that's that gastric part. So gastric can play a huge role in someone's ability to breathe, and so that's hopefully something I've highlighted for you. A, B, C, D, F, G, H, so we've just finished G, which is gastric. H is the hilar area, and so that's what we're looking at here. So that right hilar point and that left hilar point here. So this is the area sort of surrounds that central part of the x-ray. So here you're looking at the pulmonary artery. And so if someone had a saddle pulmonary embolus, where there's a giant blood clot that's just sort of developing right there, then you're going to see accentuated markings. You're going to see a lot of markings in the central area. There's a lot of things that can cause hilar infiltration, and you'll have a lot of your patients that have hilar infiltration because a lot of your patients will have pneumonia, and pneumonia can cause hilar infiltration, because the hilar infiltration is usually caused by a lot of lymphatic vessels being overloaded. And that's what you're traditionally looking at there when you're doing this. So that's something just to pay attention to. So when we're going in here you'll see some hilar inflammation, right? This is a little bit more than normal. This is more accentuated than normal. Here you're seeing it here as well. So there are a number of things that can cause this. Like I said, the lymph tissue inflammation can cause. There's so many different things that can cause this. It's just something more to take note of than anything else. Here you'll see it, how full the hilar space is altogether. It almost looks like that sail sign, like an old sailboat triangle, like the thymus sign that you see with little kids. It's called the sail sign. It's a sign that hilar space is really filled with it. And then you'll obviously see that mass, or see how dense this is. Instead of having a bunch of gas here, right, we see just how dense and full this is on the lateral chest X-ray. So that's a bad sign, right? And you can sort of see that CP angle go down and up again. So you'll see that there's a lot of density there. So there's a sign of fullness. It could be a number of different things. So this is one of the things that we'll look at here too, is some of the masses that can be developed into this area. Pretty significant, the AP and the lateral. So that's something just to take a look at. Hopefully you would notice something like this going on. And this is something usually they would get a CT scan and we'd try to go further in depth. Sarcoidosis is something as well that you would see with accentuated hilar areas, right? And so sarcoidosis also includes ground glass opacities. So GGOs is what they're called, ground glass opacities. And these looks like someone crushed a bunch of glass into like little pebbles and sort of threw them on the X-ray. So you can see when you're looking at the interstitial space, you see how it looks like someone just like threw and there's specks of glass. So it looks very spotty, right? It looks very speckly. That's what's called ground glass opacities. And so sarcoidosis means there's a lot of scarring tissue, and we'll talk about it in our ILD lecture in disease class, but there's a lot of that going on. But one of the things that you also see with sarcoidosis is that hilar region infiltration as well. So A, B, C, D, E, F, G, H, hilar was the last one we went, and then I is the last one that we'll go over here, and this is the interstitial space. So interstitial spaces, those tiny little air spaces, and so usually you won't notice this unless they have something significant going on. This is a better picture of an interstitial lung. You see how this is just like dense scar tissue, like it's been scarred up like a burn victim's skin, right? You sort of see how it's just scarred up here. And so this is all just mostly scarred up interstitial space. So it's pretty significant. And so it's something that you'll see here. So we're going to be looking at the interstitial spaces for this sort of hazy ground glass appearance. Right? So one of the things that you'll be looking at in your critical care career, if you guys do critical care, is going to be ground glass opacities and ARDS, right? So this would be an example of a normal. You see how radiolucent or how dark this is. Here's your moguls, right? And then your lungs are looking good. Your cardiothoracic space is looking good. You have good CP angles. But over here, what do you notice? Right? It's very hazy, very fuzzy, very cloudy in appearance. And then you're going to see a lot of these ground glass opacities going through. So these are just something I wanted to show you guys here. When we're looking at pneumonias, remember pneumonia is inflammation of your respiratory zone. So that's the interstitial space. And so when we're looking at these pneumonias, and infections, you're going to see a lot of these ground glass opacities. So both of these are viral patients. This is the H1N1 patient over here on your left. And then over here on your right is a COVID-19 patient. And so you sort of see how hazy ground glass, how speckly these patients are. Especially with virals, they tend to have, I call them fingers, but they tend to have, I hope you guys can all see this, streaky lines like spider webs you guys see all these like spider web lines that are going through? And I hope you can. I really wish I had a better way of teaching this. So these streaky spiderweb signs, and they're all over the place, and they're more accentuated on the COVID-19 patient. When you're looking at these things, that's a big sign of a viral pneumonia that you're looking at. And I have a comparison coming up soon. But so you're sort of seeing that these viral pneumonias can be very, very encompassing throughout all the lung regions. It doesn't usually just attack the right lower lobe. It doesn't usually just attack an upper lobe. It attacks the lungs altogether, and it can make for a really, really bad situation because you have inflammation, swelling, and effusion and pus that's going into the respiratory zone, causing all this white, hazy looking stuff. And that white, hazy looking stuff represents a hard time getting oxygen to diffuse into their bloodstream. And so this is where we're going to have why we have big issues here. Now here you can also see on this COVID patient on the right, you can see their ET tube in there, right there. So for an adult, you want the ET tube to be below the clavicles and above the carina. Roughly, it should be, according to Egan's book, 1 to 3 centimeters above the carina. In a kid, in a neonate, it should be just below the clavicle, at or below the clavicles and above the carina, because depending on how big they are, it's going to be different for. So that's why we don't actually use a numerical measurement for kids. It should be at the clavicles or below, and then above the carina, which you can see here. Like I said, if you can't see the carina right now, that's something that takes time to develop. Reading an x-ray, ultimately, when it comes down to it, takes time and patience. And the more you do it, the better you'll get at it. So don't ever stop looking at it. When you see a physician looking at an x-ray, when you see someone looking at an x-ray, take time. Tell me what you're seeing, right? Go up to them, show me what you're looking at, show me what you're seeing. How do you go about it? And this is me just going through how I go about looking at an x-ray from the training I've gotten from other healthcare providers with you guys. So here's that slide that I was talking to you about that looks at a normal x-ray versus a bacterial pneumonia versus a viral pneumonia. And here you'll see the bacterial pneumonia is more of a solid cloud than these fingers. I don't know why I call them fingers, right? So you see all these like streaks, like spiderweb streaks or fingers is what I kind of call them. So those are more common in your viral pneumonias. It's also common that streakiness is also common in cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. So pulmonary edema, you'll see those streaks, but it's because of blood vessels being enlarged. But what you're looking at here is that viral pneumonia where it just has those fingers or those streaks that are going sort of all over the place. And then here's your bacterial pneumonia, your right upper lobe, and this is a kid, right? And so this is just an example. Now, kids that lay on their back most of the time, so you're like 6 months or less kids, tend to get more pneumonias and bad stuff in their apices because they're laying down more often. Us adults tend to get them in our bases. But this kid on the right, this viral pneumonia, this is also a neonate or x-ray. You're seeing this viral pneumonia that's probably from RDS, from RSV. And that's one of those things where you'll see, if you work pediatric patients, you'll see RSV can cause this and ultimately cause RDS, which is baby ARDS. So here you see the bacterial pneumonias are more of a solid. They don't have near as much fingers, near as much streaks to them as you see with the viral pneumonia. So like I said, it's going to take seeing these more and more and more and more. This is an art. It is not as much science, unfortunately. So it's like flashcards. You just gotta go through them over and over and over again. Alright, so this is the fun part where I get to ask you what's going on here. So here's the question. What's going on here? And here it's a pretty significant thing, right? Here's a hint. They have hemodynamic changes with this. Hopefully you can see this. Alright, I'm going to start off by highlighting their trachea for you, if I can. It's all the way over here. Yep. This is their heart. Here, let's go to yellow. This is their heart. Notice here that you have this line, right? This is their rib, their rib cage, and all this is very radiolucent, right? Lucent, Lucifer, dark, right? All this is radiolucent in here. So this is a tension pneumothorax. So this is a pneumothorax. So this is air in that pleural space that's crushing the lung against the right lung against the left side. That's why the trachea is shifted. And that is a board exam question. They'll be like, hey, their trachea is shifted to the left and there's absent breath sounds on the right. Well, that's because there's so much air pushing the lungs over that the trachea is being deviated over, and that's why the breath sounds are absent over on the right, and then on the left you'll see their trachea. Their trachea is being pushed away, right? It's being crushed and pushed away. What is going on here? What do you notice? I'll give you a hint. The heart looks tall and narrow. We do have our three moguls. Hey, we have great CP angles. Apices. Do you see any coin lesions? No. Bases. We see good CP angles. C cardiac. It's tall and narrow. That could be indicating something. D is diaphragm. Oh, let's count the ribs. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Is 10 ribs normal? Yeah. All right, A, B, C, D, E, esophagus, nothing in their esophagus. F is for fissures. Do I see any fissures? No, I don't. G is for gastric. I don't see a gastric bubble. H, hilar. Well, yeah, there's some hilar stuff going on here. I is for interstitium. Man, I have a lot of density in this area because it's a pneumothorax, right? This is the lung that I just outlined on the right side. So this is a right-sided pneumothorax. The lung is so condensed and squished. All of this here, and let's use red. All this here is a pneumothorax. All that there is a pneumothorax. That's pretty crazy, right? And so here's your carina, which I know all of you guys love it when I do this. So all this is that pneumothorax on that right side, causing that pushing of the lungs into that small space over there. Now, obviously, notice what happened to the trachea. The trachea got deviated towards the left. So the trachea deviates towards the opposite side of a pneumothorax. That is a board question. I promise you, that is a board question, right? They'll give you the trachea is deviated to this side. Which side is the pneumothorax? Well, it's the opposite side of the tracheal deviation, right? That's one of the things that you'll be looking at. All right, blebs. I want to talk about this real quick. COPD emphysema patients. This is something that you got to pay attention to, especially if you put them on a ventilator. They have these sort of weak areas down in your lower left here. I've sort of highlighted that bleb. It's sort of like an aneurysm, like where you have that weakening of an arterial space. It sort of has that weakening, and it's very, very prone to rupture. And this is of the lung tissue because they have such advanced lung tissue. And here's a CT image on your upper left. And so you can sort of see the walls here. And so this would be the spinal column down here. The sternum would be up here. And so this would be the patient's actually with the right lung and then their left lung. So CT images, they're mirrored, sort of like Facebook Live. It's a mirrored image. So even though we know this is the spine, this is the sternum, and this should be the right lung, that should be the left lung, it's actually switched. Like I said, Facebook Live. So notice that the heart's mostly in that left side there. That makes sense, right? So you can see all these bubbles are actually blebs. These are these aneurysm-like looking things. So on an x-ray, that's why I put the x-ray here, you can see all these bubbles, all these blebs. So this means you put this patient on a ventilator, just be careful, because what happens if you put too much pressure on a weak tissue, right? It can make it worse, and so that's what we're looking at here. You just don't want to exacerbate that, because when you burst one of these, then it's called a pneumothorax, right? So I've taken care of and vented some of these patients, and you just got to be gentle with the ventilation numbers that we're using. Ooh, what's going on here? I love these ones. All right, so what do you think's going on here? So A through I, apices. I don't see any coin lesions. Bases, I see good CP angle. I don't see anything over here on my left. ABC, D, diaphragm. 1, 2, 3, 4, 5, 6, 7, 8. Maybe a 9th rib. So we're hypo to normal inflation on the right side. On the left side, I don't see any aeration. So I got 0 ribs on that left side. A, B, C, D. E, esophagus. Well, there's nothing in the stomach. This is my gastric bubble. Nothing in the stomach. F, I don't see any fissures. G, gastric. I don't see that. H, hilar. Yeah, there's a bunch of hilar stuff going on. I, interstitium. I really don't see any ground glass opacities or anything like that. What do I mostly see? What do you guys notice this? This is the endotracheal tube. It has a radiopaque line on it. And this is supposed to be, here, let's use a different color. Let's use green. This is supposed to be the carina. What do you notice about that yellow line? It goes into the right mainstem bronchus. So this is a right mainstem intubation. So the ET tube got inserted into the right mainstem, which means there's no gas that's going into the left lung whatsoever. So the big thing here would be to pull back. So this is a neonate or a pediatric x-ray. So very easy to happen with these kids because you don't have a lot of wiggle room between where their clavicles are and their carina. So it's very easy for that tube to enter into that right side over there. So this is a right mainstem intubation. All right, we covered this one in our pulmonary A&P class. What do you see here? I'll give you a hint. It goes along with the bark and cough. All right, here's the carina. Hopefully you guys are able to see this. Like I said, the more you do this, the better. Notice that the trachea has a funny shape to it up here. It comes to a point, right? So this would be your LTB or croup. That's that steeple sign. That's what you're seeing there. You notice that this is showing a viral pattern in the lungs. Do you guys see this? Do you see all these viral pattern things? You see a little bit of ground glass opacities, right? You see all these little fine dots all over the place. Those are the ground glass opacities that go along with interstitial or inflammation that's going on. Ooh, what's going on here? Shouldn't take you too long. Should jump out at you, especially a kid that has difficulty breathing. Sudden onset. There you go. All right, so here's the kid's trachea, mainstem. Right, so this went down the kid's right mainstem. That's also why you see that right lower lobe atelectasis, or that higher density in that right lower lobe, because this is sort of blocking gas from flowing into that right lower lobe a little bit there. The right middle lobe is anterior, and then the right lower lobe is posterior. Right lower lobe is anterior, right middle lobe is posterior. So that's why you might hear abnormal breath sounds in one of those areas. That's what's going on. And this is just sort of an AP and a lateral of sort of the same thing. You sort of see and it's not the same child, obviously, a different situation here. But you see how this is going down towards the right mainstem. Because remember, the right mainstem is usually about 25 degrees. 25 degrees. When you're looking at the lateral, you sort of see it get wedged into that space there, and this would be your cardiac silhouette here. That's your cardiac notch, your silhouette there. So it's sort of wedged there. So what type of bronchoscope would you think they would use for this? Hopefully you said rigid. All right, what is going on here? Well, let's go through the A through I on it. All right, apices, I don't see any coin lesions. B is bases. I see good CP angle. I see a good CP angle. C, cardiac. Oh, well, I really don't see good moguls. That heart is tall and narrow. All right, A, B, C, D, diaphragm. Let's count. 1, 2, 3, 4, 5, 6, 8, 9. Yeah. So good volume. A, B, C, D, E. Esophagus. I don't see anything going in the stomach. F. I don't see any fissures. G. Gastric. We see a small bubble. Doesn't seem to affect the costophrenic angle much. G. H. Hilar infiltrates. Of course, yeah, there's hilar infiltrates going on here. A lot of things can cause that. G, A, B, C, D, F, G, H, I, interstitium. So what do you notice about the interstitium? Well, I noticed that I got this solid line here, and then this is very radio opaque inside, and then outside it's very radio lucent. So what do you think caused this? Right? This is a classic pneumothorax. Well, okay, great. Well, what caused the pneumothorax? Well, what do you notice here? This thing terminates in the superior vena cava, and it was inserted behind the clavicle. So this is a central line that they tried to do subclavian to go into the superior vena cava, right? A central venous line. And then what do you notice is behind the clavicle, where this line is being sort of woven into the superior vena cava? Yeah, the lung. The lung's right behind the clavicle. So is it possible that they could cause a pneumothorax while placing a central line? Absolutely, especially if it's a subclavian line like what you see here. So this is them inserting a CVP. So one of the classic things they do after they insert a CVP is go ahead and get a chest x-ray to sort of rule out this type of situation, or to make sure if it does happen that we take care of it early on. Ooh, what's going on here? So nothing really going on here. We have a neonate, and this is a premature kid, and this is just sort of a kid that's intubated. I just want to show you guys how small they are. And here, I need a more steady hand. Is their carina? So it's below the clavicles and above the carina, and this is the radio opaque line that you see here. Let me use the yellow for this. This is the radio opaque line that they put on all the ET tubes so we can see them easier on an x-ray. So it's above the clavicles, but you see this kid's so premature, and you see the cardiothoracic ratio. This is normal. This kid does not have cardiomegaly. That's a normal cardiothoracic ratio for a kid that's premature like this. And this is where you're seeing all these ground glass opacities because this kid doesn't have surfactant yet. Right, so this is a premature baby x-ray. So that's what you're looking at here. So I just want you to sort of see some differences and get you guys a variety of different looking x-rays.